Hello, everyone. I hope you had a lovely lunch. I'm excited to be back here for day 2. So today we're going to cover treatments based on differential reinforcement, talking about functional communication training, like Sungwoo mentioned, but going into a little bit more depth about it today, and then talking about competing stimulus assessments in part 4 after the break. And then at the end of that, I'm going to talk about what the admission process usually looks like from start to admission, from when we get the referral all the way through to discharge and providing follow-up services. But before I begin, I just wanted to note that all of the procedures that I'm talking about, both today and yesterday, are the gold standard in the field. There are modifications, and we talked about a few of them yesterday, and I'm going to talk some more about them today. But it's very important to understand all of the procedures, these gold standard procedures that I'm talking about, both with the functional assessment, preference assessments, and the items that I'm going to talk about today. Because it's not only important to know how to do these procedures, but why you're doing them in the first place. So hopefully from yesterday and today, you guys have a deeper understanding of why we're doing these procedures, even if you've maybe learned about them in classes. Because I do know that there are some BCBAs in the class. We have a really wide range of people in the audience, some people who are BCBAs, and some people who may not have had any experience with behavior analysis at all. So if you are someone who's more advanced and you have questions on doing modifications, please ask them during the Q&A. I do have lectures that I give that are more advanced topics, and so if you're interested in that, feel free to ask those questions. And I also wanted to briefly mention, as I'm talking about modifications, there are some modifications that might be necessary for adults. So after yesterday, you might be asking, oh, isn't this what we do with kids? And the answer is yes, a lot of the procedures are very similar. But in order to know the modifications that we do for adults, you have to understand this gold standard first, which is why we're covering it today. But some challenges that are commonly cited with adults that are experienced, at least not to the extent by children. One is legislation and cost. So at least in the US, there's typically less money for adults compared to children. I won't bore you with how all the funding works in the US, but essentially for children, their services are funded not only by the school systems, which have some money, but also private health insurance will also pay for ABA services. But once individuals turn 21, they lose access, obviously, to the school services, and a lot of the states, every 50 of the US states is different, but most of them no longer cover ABA services for private health insurance, and so they rely on state funding alone. So all that being said, there's less money for adults, and so as BCBAs, we have to be as time efficient as possible. But we cannot compromise the effectiveness of what we're doing. So doing a functional analysis and finding out why the problem behavior is happening is a crucial first step. I wish I had a magic wand. If somebody's tantruming and they're like, oh, Julia, make it stop. I wish I knew how. But that has actually happened before when I'm consulting. I get there, I've never seen this person before, this adult client, and they're having all this problem behavior, and they're like, oh, what do we do? And I don't have a magic answer. My first question that I'm going to answer myself as the clinician is, well, why are they having the problem behavior? And I'm going to answer that by doing a functional analysis or some of the other procedures that I mentioned yesterday. I know we have some psychiatrists in the audience. I'm sure you wish we had a magic pill, a magic medicine that we could give, and we don't. So doing that functional analysis is very, very important. And today we're going to focus more on some treatment options. And so before I move on to treatment, though, I mentioned that we want to be as efficient as possible without compromising effectiveness. And we did talk yesterday with in the FA section, some ways to do that. One was switching to a different format of a functional analysis, like the latency-based, and also identifying those idiosyncratic functions as well. So today we're going to focus on treatments. So I talked about one commonly cited challenge in adult services, and that is legislation and cost. The second one is the complexity and severity of problem behavior often is more heightened in the adult service setting. A lot of times the adult clients have been engaging in these problem behaviors for years, since childhood to present. So we have a much longer history of reinforcement, which makes it more difficult to treat. Oftentimes, they're more complicated as well. We see a lot of clients with comorbid diagnoses. Autism's not their only psychological diagnosis, and so that makes it a little bit more difficult. And also talking about the severity, I mean, you saw some of Sungwoo's videos of children. Imagine those individuals when they're 25 or 26, a lot bigger, even 30. And so there are some considerations that you have to make in those situations. And so I'm going to talk about some of those today when I go through functional communication. In your slides and your handouts, we're going to talk about functional communication training with extinction, as Sungwoo described today, and that's the one that we're going to practice. Because if you can do that, it's most ideal. But often you can't implement extinction, especially with adult clients. And so when we get to that section today, I'm going to talk about that specific challenge with adults as well, and talk about functional communication without extinction. And the third commonly cited challenge in working with adults compared to children is, at least in the US, the qualification of staff. So I mentioned that for children, they get funding from school systems and private health insurance, and they require a lot of certifications. So the staff, their master's level clinicians have to be at least a BCBA, and the direct care staff or aides working with them have to be registered behavior technicians, which is another credential that the BACB, the board that certifies behavior analysts, gives out. And so with adult services, though, the state only requires that you have, typically, it depends on the state again, but typically it's just a high school diploma and some state mandated trainings that anybody can complete. So the qualification for staff is vastly different as well. Some states do require, are starting to require BCBAs for master's level clinicians, which is great, so things are getting better. But still, the qualification is a lot different. And so there has to be a heavy emphasis on caregiver training for BCBAs, especially. So if you are a BCBA working in the adult service setting, you really have to rely on the regular caregivers. And so you have to really emphasize caregiver training. And so if any of these things that I'm mentioning are something that's you're really interested in, please ask during the Q&A, because I wish I had time to talk about staff training today, but I don't. But we are doing a lot of research in the adult service setting to figure out ways to more efficiently train staff without compromising effectiveness. That's really the key for adult service in general, because there's not a lot of time, not a lot of money, not a lot of qualified staff, so you have to be, as the qualified clinician, as efficient as possible, both time efficient and resources and money efficient, without compromising your scientific efficacy. And so keep your questions, write your questions down as I go today, and if anything I just mentioned is interesting to you, please ask during the Q&A, or email me. I'm not going to disappear off the earth once I leave Korea, so I'm happy to answer all of your questions, or you can just ask Erin, and she knows how to find me. All right. So in this part, before the break, we're going to cover how to prompt adults specifically, especially if you're a BCBA in the audience. I'm sure you've heard of prompting hierarchies before, but I'm going to talk about some special considerations to make when you're working with adults. Then talk about functional communication training, and also how to just generally increase compliance. And a lot of this is going to tie from yesterday, so we're still going to talk about Bruce today. So we have done preference assessments with Bruce. We know he loves his iPad. We've done reinforcer assessments with him. We know that he's willing to work for his iPad. And we've done a functional analysis with him. We know that his self-injury is automatically maintained. And we know that his aggression and disruption are maintained by escape from demands. So today, what are we going to do with all that information? We're going to answer that. So for this part, the handouts that you guys will need, we're going to talk about his treatment protocol again, and also the functional communication training session description. And that will be one of the role plays that we do today. So, talking about instructions. So when to prompt our adult clients. So a lot of things can be considered an instruction. So if you're walking with a patient or a client and you're telling them to cross the street, it's important to get to the other side of the street, right? There's traffic. Even social questions or any kind of questions can be considered an instruction. So if you're at a restaurant and your waiter asks you, "What can I get you?" That's a form of an instruction. They're asking for you to provide them more information. If your house is on fire and a firefighter tells you to evacuate the house, that's a very important instruction, but an instruction nonetheless. If it's raining outside and you're telling your client, "Oh, grab your umbrella on your way out," that's an instruction. Even doing homework. If your teacher tells you to do your homework, that's an instruction. So the instructions that are very important are the ones that are related to health and safety, and we prioritize those. So of these examples here, crossing the street and evacuating a burning building are very important. So for the crossing the street, let's say you get halfway to the middle of the street and your client drops to the ground. We have to get to the other side of the street, otherwise we're in some serious danger. Same with a burning building. Very, very important, and different than the other kinds of instructions. We usually separate those into essential instructions, which are related to health and safety, and non-essential, which is everything else. So why is this important? When working with adults, they have the right to refuse. If you tell me, oh, Julia, it's gonna rain outside, grab an umbrella, do I have to do that? No, I'm a full-grown adult. I can decide to get wet and not use my umbrella. I can do that. If you say, Julia, do your homework, I can choose to get an F on my homework. Nobody can make me do that. Nobody's going to do that because I'm a full-grown adult and I have rights. Adults, clients that we serve, have the same rights as you and me, and so we have to honor that. So let's take, for example, the umbrella. Okay, so we're working in a group home with an individual, it's raining outside, and we say, oh, Jimmy, go grab your umbrella because it's raining outside. And Jimmy says, no, I don't want to grab my umbrella. So it's not immediately affecting his health and safety, but it is kind of important. So what are we going to do? Are we going to force him to grab his umbrella, take it and put it in his pocket? It's not the best course of action. We never want to engage in power struggles, as we call them with our clients. What we can do instead is say, okay, you don't want your umbrella? Well, how about a rain jacket? And Jimmy says, sure. So if something is still important, but it's not immediately related to their health and safety, we can offer them different options. If it was the homework example, and you say, Jimmy, do your homework, and he says no, okay. You have the right to say no to doing your homework, just like I do. But now, I'm telling you that adults have the right to refuse, but we also have a duty to keep them safe and healthy. So let's take for example, the house that's burning down. So a firefighter comes and they're like, your house is burning down, you have to get out. And your client says, no, I'm gonna stay here. We might have to do some physical prompting in that case. And so what I'm gonna talk about now is how do we assist our clients? And how do we do that? And at what point do we maybe have to use physical guidance? Because sometimes physical guidance is okay, especially if we're teaching a skill. They might be totally okay with it and it's just being used there, and it's not a power struggle. And so that's what I'm gonna talk about right now. So in the treatment protocol that you guys have, there is a section, it's component number 2, that covers SPEAR prompting. So SPEAR stands for, it's S-P-E-A-R. S is say, P is pause, E is exemplify, A is assist, and R is reinforce. So I'll break those down one by one, starting with say. So we always provide the verbal instruction in clear and concise language, especially with individuals who have some communication issues or some intellectual disability. Less is more. You want to keep the instruction as simple as possible, and you don't want to confuse them with extra language that might be necessary. So if it's to, pick up the water bottle, I'm going to say, pick up the water bottle. I'm not going to say, oh, Julia, can you please pick up the water for me, please? That would be so nice. It's a lot of extra language that might confuse them. Just be clear and concise. Pick up the water bottle. It might not be necessary if you have an adult client who can engage in conversations and has those kind of communication skills. You can maybe include more language, but just as a rule of thumb, we usually say to be concise. And I have a video example here.
Bruce. Fold the towel.
So that's it, just fold the towel is the instruction. So after you provide the instruction, you're gonna pause. We usually pause for about 3 to 5 seconds to allow them to respond. And this you can change depending on the client. We recently had a patient who had some cognitive delays, and so we actually changed this to 10 to 15 seconds for him, because it took him some time to register our instruction. But for most of our patients, we usually wait 3 to 5 seconds, and then if they don't respond, we move on to E. So if assistance is required, we move on to the next step. If they do respond immediately, then we go all the way to reinforce. So if at any point from say to R, if they do it, great, you can skip everything else in the middle, just go straight to reinforce. So if you say fold the towel and they do, cool, folding the towel. You don't need to do P, E, or A. Just skip right to reinforce. So if we were doing fold the towel, in the video that I'm just going to show you, Tori says fold the towel, and then she allows Bruce 3 to 5 seconds to fold it on his own. And I'll show you that right now.
Fold the towel.
So she gave him 3 to 5 seconds, and you can see she's about to move on to E, which I'll cover in just a second because he did not fold the towel. So E stands for exemplify, and this is when we provide a model prompt, because they might not be responding because they don't know how to do it. It's very possible, and so that's why we have the E example here. So we tell them to do it, we wait a few seconds to see if they can do it, and then if they don't, we provide a model prompt. While we're providing the model prompt, we repeat the instruction only once. Remember, with language, less is more on the therapist's part. So fold the towel. Bruce doesn't fold the towel. While I'm providing the example, fold the towel. I'm going to repeat it once. We don't want to repeat the instruction over and over again. We call that broken record prompting, and we don't do that. So it's not fold the towel, Bruce, fold the towel. I'm serious, fold the towel. That's not accomplishing anything. So we say fold the towel once, pause, and then as we're modeling it, we provide the instruction again, and that's just because in the event that they don't know how to do it, we're kind of signaling, we're pairing the instruction with how to do it. So fold the towel. Like, essentially, this is how you do it. If further assistance is required, then we move on to A. Again, if at any point they do it, great job. We move on to R, reinforcement. And so I'll show you an example of Bruce right now.
Fold the towel. Fold the towel.
Okay, so if they're still not doing it, we move on to A, which is assist. And so this is where we have a prompting hierarchy. So to assist, we usually go from least to most. And so that prompting hierarchy usually starts with a partial physical, which is just a nudge in the right direction. And then if that doesn't work, then we move on to a minimal physical, which might be, so if it's to pick up the water bottle, for example, the first one might be just a nudge at the elbow in that direction. If that's still not working, we might move to the forearm or by the wrist. And if that's still not working, we go to full physical, which is hand over hand, assisting them with it. And I'm going to talk about what to do if they resist the prompting. That's coming right next. So this is assuming that they're okay with physical guidance. For some of our individuals who are really cognitively advanced and can engage in conversations, we also, before we get to this point, we might say, I'm going to help you, is that okay? Before we touch them. So it really depends on the skill level of your learner. So here's an example.
Bruce. Fold the towel. Fold the towel.
So that was just the nudge. That's all he needed. And here's another example.
Fold the towel.
So you move on to the steps, either if there's a
Fold
mistake
the towel.
or nothing. So she started with the nudge, that wasn't working. She's moving more towards the forearm, and now she's going hand over hand because he still wasn't doing it. So now I mentioned if at any point Bruce engages in problem behavior or resists the physical prompting, we stop. Like I said, we don't prompt over active resistance. So if I'm saying to, I'm doing the hand over hand and Bruce is like pulling away, I'm going to stop. Same with problem behavior. So if I say, and this will change depending on if they're in treatment, but this is just a general baseline of what we teach our staff. So if you say, pick up the water bottle, and then you did the model, and now you're fully prompting them, and then and then they go back to hit you, we would back off for a moment. That is potentially reinforcing the problem behavior, especially if they have an escape function. But it's just when you have adult clients and they're very, very large, sometimes you can't implement extinction. And that's why we're going to talk about it a little bit today. So we wait for Bruce to no longer be engaged in the problem behavior or resisting before we then go back in with that instruction. And especially if we're trying to not reinforce problem behavior, it is important to go back in and provide that instruction and continue to try so that they're not getting escape. And we're not reinforcing the problem behavior. So I'll show you, I have a couple examples. I have an example of problem behavior and an example of resistance in this video.
Fold the towel. Fold the towel.
Resisting, she steps back for a second, and then she resumes where she left off. So she left off in A, in assist, and so she went back in at assist, and he folded the towel. But she had to do it for him so he does not get reinforcement, which we'll talk about in a moment.
Fold the towel. Fold the towel.
So when the problem behavior happened, she backed off. She's not engaging in that power struggle. Not only is it questionably ethical to do that to the patient, but it's very dangerous for the staff too. Before I worked with adults, I was working with adolescents at a different center, and I was not a BCBA yet either. And I was told to make sure you implement escape extinction. Make sure that you hand over hand to do it. And that was a power struggle, and she actually fell onto my knee, and I tore my ACL, which is not a fun injury. So that's why I tell my staff to just back off for a second, because you got to keep yourself safe and the patient. So you might be reinforcing the problem behavior, and if that happens, it happens. It's not everything is clear, a clean reinforcement, extinction, and everything in adult services. Sometimes it gets a little bit messy, and if that's the case, then you just have to be more creative with your treatment options, and that's why, especially in our clinic with adult services, we have to implement some treatments without extinction, meaning that the problem behavior might be reinforced even when we have a treatment plan in place. And I'll talk about what we can do about that later on. But as our SPEAR prompting, we train our staff, it's generally to just back off if problem behavior is happening. If it's really mild problem behavior, or if it's not that dangerous, like let's say the most severe problem behavior they have is just hitting the table, you could probably just do escape extinction standard, just like you could do with small children, because it's not as dangerous. And then you're not reinforcing the problem behavior. So it depends on the client too. This whole SPEAR prompting, it's not the only way to prompt individuals. So it's not the only way to prompt adults. It's just the way that we do it, and we find that it works for us. And this is based on also not just our experience, but literature as well. So this is what we do, but everything that we do is modified for the individual depending on their severity, their size, their skill level. But this is just what, when we have new hires, new staff or new BCBAs, we train them on how to do this. And so for most of our patients, this is what we do, but not everybody. Sometimes they need a more individualized protocol. All right, and the last step, which we already kind of talked about, is R, reinforce. So we provide praise after a directive is completed without problem behavior or resisting the prompt. So as long as they didn't resist the prompt or engage in problem behavior, great job, Bruce, folding that towel. Give you an example of the whole SPEAR prompting.
Okay, Bruce. Fold the towel. Fold the towel. shuffle on that towel.
So that's spear prompting. So that's generally how it goes for non-essential instructions. If it's non-essential, they resist or they have problem behavior, we're just gonna back up to keep everybody safe. But what if they are in the middle of the street or the house is burning down? We can't just okay, no, it's fine, you can stay in the burning house. We're not gonna do that. And so we might need to do the physical prompting anyways, even if it might be over active resistance to make sure that they're safe. And that's when we use more physical management to try to escort them maybe across the street or outside of a building and still do the A and that physical portion of the assist step, even if it's over resistance, because we have to, making sure they're safe is the utmost priority. Okay, so now I'm going to talk about component 1 and how that relates to extinction that I keep talking about. So extinction is withholding reinforcement for a previously reinforced response. And so that means that something was reinforcing the problem behavior, and now you're not giving it contingent on problem behavior. So for example, attention, in the functional analysis, they engage in a problem behavior, and you're, ouch, that hurt, don't do that. So you give attention for the problem behavior, right? But then in treatment, they engage in problem behavior. I'm going to say nothing because your attention is reinforcing the problem behavior. So when you're implementing extinction, they engage in problem behavior, you're going to not say anything. You're going to ignore the behavior. And when I say ignore the behavior, sometimes people take that differently. I'm saying to ignore the behavior, not the person. You're never going to ignore the person. You're still going to attend to them, make sure they're safe. Any appropriate requests that they have, you're still going to provide. So you're still going to make sure, you're still going to attend to them, but not the behavior. So you're not going to say, oh, that's so terrible, don't do that. Sometimes, especially when we're doing parent training, it's very tempting to provide like a reprimand and tell them not to do it. But if a patient does have problem behavior that's maintained by access to attention, you just have to explain why. And sometimes going through your functional analysis is important. And telling them, hey, we did our allergy test to see when they engage in problem behavior, and we found that when we provide attention, even if it's a reprimand, they engage in more problem behavior. So it might be tempting to provide attention, but try your hardest not to. And so here are some do's and don'ts that I've seen throughout my career. This is a do. Nothing. Got to practice your poker face sometimes. This is a don't.
Bruce, you're gonna break the window.
Oh, sorry, it's a little loud. So that's a don't. This is also, oh wait.
Bruce, you're gonna break the window.
Sorry, I went back. Okay, this is another don't. Even that little sigh sometimes is reinforcing. I'm serious. So even just like or even just like an eye roll could be reinforcing. So if somebody has a problem behavior maintained by access to attention, poker face, no response, that would be true extinction. So for tangible items, in baseline, like in your functional analysis, they engage in the problem behavior and you gave them the iPad. So the iPad is the reinforcement. So to be extinction, they engage in problem behavior, they don't get their iPad. Okay, so here's a don't example.
You can have it.
That's not good. And a functional analysis that is good because we're trying to see if that is the reason he's engaging in problem behavior. Because that's our allergy test, right? We're seeing that in this context, are they engaging in problem behavior? But once they're in treatment, it's not good. And for demands, so in the baseline, we're doing work, they engage in problem behavior, they don't have to do it anymore. In treatment, they engage in the problem behavior, they still have to do it. And so I mentioned that when I was going over SPEAR, that is escape extinction. So if you're saying, fold the towel, and he throws the tissue box, you're going to keep going with, you're going to then provide the example. If he engages in problem behavior, you're maybe going to back up for a second and then try to go back in to get that done so that he's not getting out of doing it. We don't want to reinforce the problem behavior. Not always possible, and I'll talk about what to do when you can't. But this is what extinction is, if you can.
Bruce, Write your name.
This is a don't.
You don't have to do it, Ianna.
Yeah, that's not great. This is a do.
Write your name.
She's ready.
Write your name.
So she kept going with the spear prompting. So she gave the instruction, he engaged in a disruption, and she had another pencil ready to go. Which usually we are. If we have patients, we know their history, we know what they're capable of, and we make sure that we're ready. So she had a pencil in her pocket just in case that happened. We have that with like worksheets too. We might have extra worksheets here, so sometimes they'll engage in they'll rip the worksheet. It's like, okay, well here's a new worksheet. Do the worksheet. And so that would be escape extinction. And in this example with Bruce, it's possible. There's no power struggle. She just pulled out a new pencil and gave the instruction again. So that's very possible to do. So for Bruce's treatment, it says planned ignoring. It doesn't say extinction, and that's just because the text here says to not provide any forms of attention. If you recall, Bruce does not have an attention function, right? He doesn't engage in any problem behavior for attention. But nonetheless, it's best practice to not provide attention just in case we don't want to accidentally create an attention function. Just because he doesn't have one now doesn't mean he might not in the future. And so it's just best practice to always less is more when they're in treatment, to not provide attention. And so that's why it's called planned ignoring for him, not extinction, because he doesn't have an attention function. But it's essentially procedurally the same thing, to ignore the behavior. All right, so now we're going to move on to functional communication. And I'm going to try to go through this part a little quickly because Sung-Woo did a great job of reviewing it this morning, and then I'll talk more about when you can't do extinction. So really quickly, to answer what is differential reinforcement, this is a procedure in which a previously reinforced behavior is placed on extinction, while a second behavior is reinforced. So if any of you took coursework on behavior analysis, you remember B.F. Skinner and his pigeons, where all of our schedules of reinforcement came from originally. So you have two behaviors. You have behavior 1 and behavior 2. One of them has been reinforced in the past. So let's say it's the red one. It's behavior 1. So the pigeon pecks and he gets food, right? That's classic Skinner, years ago. So that is just reinforcement for one behavior. And now, let's say you want him to switch to behavior 2. You're going to cut off reinforcement for behavior 1, no more food pellets for behavior 1. Now if you peck behavior 2, you can get food. So we would expect that if you're not getting anything for behavior 1, but you are for behavior 2, the pigeon would switch. And they usually do. And then we call that differential reinforcement. So that's the basics of differential reinforcement. And a lot of applied behavior analytic procedures are based on this one simple foundational concept. One of them being functional communication training. So there are two forms of differential reinforcement in Bruce's treatment plan. So when we're talking about differential reinforcement, remember there's always two behaviors, one we're not going to reinforce and one that we are. So for Bruce, behavior 1 is problem behavior. Specifically, we're targeting his aggression and his disruption with differential reinforcement. So the two behaviors that we are going to increase, he has two components that use differential reinforcement. One is functional communication. Functional communication is a form of differential reinforcement of alternative behavior. And he also has another component. He has a token board that you can see right there for increasing compliance. And so we're going to talk about both of them, but first start with functional communication. So functional communication, Sung-Woo did a great job talking about it this morning. So we are going to teach, so behavior 1 is problem behavior, behavior 2 is an appropriate communication response. So let's take Susan, for example. Her functional analysis indicates that she engages in aggression for attention. So in baseline, she engages in problem behavior, she gets attention. During treatment, maybe her functional communication response is play with me. So Susan says, play with me, and we're like, oh, sure. Definitely, that's behavior 2. What's going to happen for behavior 1? No attention. So if Susan engages in aggression in this treatment, we're going to do poker face, just like Tori did. If she engages in the functional communication response, play with me, please. Oh my gosh, sure, of course we can play with the level of enthusiasm as Sung-Woo staff had this morning. So the treatment evaluation for Bruce, this is one of the handouts that you guys have, FCT treatment evaluation. And so we'll go through that one now and then maybe do some role play practice. So for Bruce, we're doing functional communication to teach him how to appropriately get out of doing work. Because we did our functional analysis, we did that yesterday. He engages in aggression and disruption to escape demands. And so now we're going to treat it. So his functional communication response is going to be some form of, I don't want to do it. So we're going to start out just like we did in the functional analysis. We're going to start out in our aversive situation. Hey, we're going to do some work right now. And then we're going to train Bruce an appropriate communication response. So in baseline, though, we have to, so some of you guys might be familiar with experimental design and how we decide if a treatment's effective or not. I'll give a quick Cliff Notes or a brief version if you're not familiar with experimental design. So in any kind of experiment, you have to have a control and a test. We talked about that yesterday. And you have to have repeated measures. And so yesterday, when we were talking about the functional analysis, we had repeated measures over all of those conditions. We did 5 series in Bruce's. You saw all of those. So that's replication over time. When we're doing a treatment evaluation, you can use all different kinds of designs. The one that we're doing today for Bruce is called a reversal design. And so the reversal design means you get a baseline first. You see how they're doing without treatment. You run a few sessions, make sure that it's stable. And then you run your treatment sessions. And then you make sure that that's stable and it's going well. And then to make sure that this reduction in problem behavior is not due to something else, because it could be. The parents could have gone to a psychiatrist and they put them on a new medication. And that's why your treatment's working. It's not actually your functional communication, unfortunately. So to make sure that that doesn't happen, you then go back to baseline. So you run your initial baseline, things are bad. You run your treatment, things are great. Then you go back to baseline. If things get bad again, then that means that that reduction was because of you. You did a good job. If you go back to baseline and it stays low, it might not have been you. And we don't want to train everybody in how to do these treatment plans if it's not what we did that caused the change in behavior. So that's why I'm going to show you some graphs of how this goes. We do a baseline, treatment, baseline, and then we go back to treatment before we do all the other things that Sungwoo mentioned, doing schedule thinning and generalization, and then finally putting it into the treatment plan. So this is the baseline condition, meaning no treatment. So this looks very similar to the functional analysis condition. So we say we're going to do some work, Bruce engages in problem behavior, we remove it, right? Because this is what it looks like without our treatment. This is what it looks like in the real environment when they're getting reinforced for their problem behavior. So this is what we're going to compare our treatment to. And so here's an example of what the baseline looks like.
All right, Bruce, we're going to do some work right now. Fold the towel.
Identical to the functional analysis. Okay, so here's how we graph and know if our treatment is effective or not. So we have aggression and disruption on this axis, and we've converted this to responses per minute. So we'll say that these sessions are 5 minutes long. However many aggressions and disruptions we have, we add that, divide it by 5 minutes, and then we graph it here. So this is our baseline. Bruce is clearly engaging in problem behavior without a treatment. He's probably averaging around like maybe 5.5. And so this is what we're going to compare our treatment effects to. So that's why it's important to do your baseline first. Before we move on to treatment, we have to teach the functional communication response. We can't just go right into treatment and say, oh, okay, now tell me that you want to play with me, and I will. For some individuals who have high cognitive abilities and verbal behavior, sure, that might be good enough. But for most of our patients, that's not good enough. You're going to have to teach them. And Sungwoo showed us an example of sometimes you have to start very small, just touch this picture, then hold it, then hand it over. Go find the person and hand it over. So you have to teach a functional communication response. So also, as Sungwoo mentioned, the response can be any kind of form. It could be a vocal statement, I want a break, please. It could be sign language, so this is American Sign Language for break. It could be a modified sign, so that's this over here. This is just B in American Sign Language. For some of our patients, like if it's for tangible items, this is American Sign Language for eat. We've sometimes just taken this They just touch the side of their face, and that's enough. So it depends on their cognitive level. Could be handing over a picture card, or it could be a speech-generating device, like a lot of the iPads or other tablets have applications that will speak for you. So it doesn't matter what it is, as long as it's appropriate, we could consider that a functional communication response. So when doing the actual training, we do it in the motivating situation. So if I'm going to teach Bruce how to ask for a break, we're going to do it during work. I'm not going to teach him during playtime. I'm not going to teach him during lunch. Doesn't make much sense. We're going to teach when the motivation is high. We're going to teach during work. To teach it, usually we use most to least prompting, and this is because we don't want them to make a mistake. We want to keep it as errorless as possible. So if we are starting very small, so Bruce, in this example, and in his profile, he only has mild intellectual disability, so we're going to assume that he can speak in sentences, short sentences. So his response is, "I want a break, please." So if we're doing functional communication, I'll tell him the rules first. I'll say, hey, we're doing work, and if you want a break, you can say, I want a break, please. And so then I say, fold the towel. I want a break, please. The full echoic prompt. And then he'll say, I want a break, please. Cool, yeah, great, you can definitely have a break. And maybe I'll do that a few more times, like a full, like fold the towel. I want a break, please. And then he says, I want a break, please. Sure, we can absolutely have a break. We don't have to do our work. And then you can fade that out. So we usually start most and go back to least, just so they're contacting the reinforcement. We don't want to make it too hard for them. So if we say, I want a break, please, is the response, we start fold the towel, and we wait too long to give them a prompt, they might just start engaging in problem behavior. So that's why we usually we make it as easy as possible, as Sungwoo mentioned, and we also start with most to least prompting so that they know how to do it and they can contact the reinforcement and not engage in problem behavior. We want to reinforce immediately. So they say, I want a break, please. Sure, get that towel out of there. We are taking a break. If it's a worksheet, absolutely get that worksheet away. Sometimes for some of our patients, we take the work all the way out of the room. Even the work being in the room is upsetting to them. So we make it as reinforcing as possible and we reinforce as immediately as possible. And then before we consider this a mastered response, we have a mastery criteria, which if you're familiar with behavior analytics skill acquisition programming, you always have a mastery criteria to know when you're done, they've learned the skill. And this is true for functional communication training as well. So for example, let's say for Bruce, we say, if he has 3 consecutive sessions with 80% or higher independence on the functional communication response, he has mastered it. At that point, we're going to put it in our treatment evaluation and compare it to baseline. Because it's not a really fair comparison to baseline if he doesn't know how to engage in the response. So we need to make sure that the response is in his repertoire before we can then put it in our treatment evaluation. So let's say that we did all of our communication training. This is a graph of his skill acquisition, learning the response. So this is scaled 0 to 100% independent responding, meaning I didn't need to give any prompts. So maybe in that first session, he was at 40%, so maybe for a couple of them, I said, fold the towel. He didn't say anything, and I had to say, I want a break, please. So I had to provide the full echoic prompt, so that one would not have been scored as independent. Maybe in session 2, that happened a couple of times. Maybe even in session 3, he was really close, and I just had to say, if I said fold the towel, and then he goes, I want a break, please. So maybe just that really short echoic was enough. And then in those last 2 sessions, we saw 100% of sessions. He did it independently. He didn't need any help from me. So our criteria was 3 sessions above 80%. We hit that, and so now we're going to put that into our treatment evaluation. So we have our baseline. Now we're going to compare it to our treatment. So what is the treatment? So this is what your handout is. So we already went through what the baseline looks like. Now we're going to talk about treatment. So we're still going to tell him, like, hey, I need to do some work. We need to do some work together, just like we did in baseline. But now we're going to add, if you need a break, you can say, I need a break, or I want a break, please, whatever the specific response is. So the consequence for problem behavior, see here it says that the problem behavior is ignored, and then specifically, just so everybody knows what that means, for Bruce, it means no escape. So you would do exactly what Tori did with the pencil. So write your name, he throws his pencil, she has another one ready to go. Write your name. So we're not reinforcing the problem behavior. So this is functional communication with extinction. So this is what you would do when you can't implement extinction, which is always best if you can. It's easy. It's much easier. It's less clinically complicated. So this is the gold standard if you can do it. And then we have to specify in the session description what we do if they engage in the functional communication response. So if Bruce says, I need a break, please, session description says, remove all the work for 30 seconds. He gets a 30-second break if he says that. And so here's an example of what treatment looks like.
Bruce, we're gonna do some work right now. Fold the towel.
I want a break, please.
Sure. Nice job asking.
Hey, I'm going to the park this weekend.
Oh, really? What are you gonna
Nice
do?
little
I'm
conversation.
gonna go with my Uncle Jeff, and I think we're gonna use the slide.
That sounds pretty exciting. You gonna do anything else?
Yeah, I like to look at the trees there.
Trees. Certain ones you like?
Yeah, the tall ones.
Sounds pretty fun. I hope you have a good time.
Yeah, I'm excited.
I'm excited for you.
So she's looking to her data
All
collector.
right, Bruce.
to
You gotta
tell
get
them
back to
30
work right
seconds
now,
is
all right? Wipe the table.
He doesn't know if he wants to do it now. So he's asking for a break quite a bit. And so he asked for the break very appropriately, and then he went to have a conversation with his caregiver, and they were talking about trees. And then you saw her looking because the data collector was going to signal her when 30 seconds was up to go back to work. And then we went back to work. So here's an example. He looks less happy. Here's an example of what to do when problem behavior happens in treatment.
All right, we're gonna do some work right now. Fold the towel. Fold the towel.
Moved right on to the exemplifying.
Like how you fold that towel. Can you wipe the table for me?
I want a break, please.
Like how I asked for a break. Sure.
Well, there you go. So she ignored the problem behavior. She just went right on to exemplify. And then he actually eventually did fold it. Then he did the next task and then appropriately asked for a break, and he got it. So on our graph, this is wonderful. Bruce is hardly engaging in any problem behavior when he asks for a break, and we give it to him. Let's say we went back to baseline, where we reinforce his problem behavior, and we see problem behavior go back up. We know that this reduction here is because of us. It's not something else that happened in the environment. So we've eliminated any confounds by doing this reversal. It's not always possible to do a reversal, and so if you can't, it's okay, especially if you're working in the adult service setting or a setting where you have a very large caseload and you might only have a few, maybe even 30 minutes or an hour with a client. You might not have time to go back to baseline. You just have to know that it's possible that your treatment's not the thing that's leading to the reduction in problem behavior, but it's okay. Their problem behavior's low. If you can do a reversal, it is ideal because behavior plans are labor intensive. It requires a lot of work, and if you do a reversal and find out that your treatment's not important, then you're saving everybody a lot of time by not training them in it. So if you can do a reversal, always recommended, but if you can't, not the end of the world. So we go back to treatment, we see near zero rates of problem behavior, which is wonderful. So then we do schedule thinning. This is just a hypothetical graph. Usually schedule thinning is a lot longer. Sung-Woo showed us a couple of graphs of schedule thinning, and he also mentioned why we would do it. So in this example, every time Bruce says, I want a break, please, he gets a break. If he's asking for a break the entire session, he's getting no work done. So at some point, we have to thin the schedule of reinforcement. And I'm not going to talk about how to do it because Sung-Woo already did a great job of how to do that this morning. And then we move to generalization. So maybe when we're starting these evaluations, we're starting them in our session room. But we need to make sure that it works in his regular environment, maybe at his day program. Or if he has a job, he needs to be able to work at his job. So we'll run these sessions in other environments. We'll also run them with other caregivers. We'll maybe have the parents come in, or we'll go to the parents, or we'll go to the day program and watch how he does with his regular staff as well. And if it's with other staff, we would make sure to train them before we run the session. So there would be like a little bit of a break there while we train staff, and then have staff implement it to make sure that it works when it's at a regular schedule of reinforcement with regular people in the regular environment before we say mission complete. Okay, so we're going to take a brief break here for you guys to practice functional communication training. So for Bruce, you guys hopefully kept your practice materials that you had yesterday. So you'll really just need the work materials to practice doing work. And you guys can practice doing both baseline and treatment. So baseline's very similar to the FA. So hopefully from yesterday you guys know how to do that. And that one's an easy review. And then move on to treatment. And so you can use the session description, or you could also use the treatment protocol to guide you on what methods to use, because we added it to Bruce's treatment plan because we found that it was effective in our evaluations. So either one, hopefully it'll be like a really quick recap. I also want to take this time to just walk around and answer any questions that you guys have, and then we'll get back to the presentation. Okay, so hopefully you guys understand how to do functional communication with extinction. I did mention that that is the most preferred way to do extinction, to do functional communication, is when you can also use extinction. Unfortunately, that's not always possible. And just recently, there's been some research that some colleagues and also myself have conducted on how to use functional communication when you can't do extinction. Prior to those studies, the research just said that if you can't do extinction, it's not going to work. So it wasn't very helpful. But if you think about working with adult clients, especially like Bruce, we're lucky that we can do escape because his problem behavior doesn't seem that severe in this video. But for a lot of individuals, in order to do escape extinction, physical prompting might be necessary, and we can't do that a lot in adult services. Same with, let's say, they have tangibly reinforced problem behavior for food in the refrigerator. And so they ask their mom for dinner. Mom says, oh, we have to eat in a little bit. You know, we have to wait. They engage in problem behavior. We told the mom to try to implement extinction, but the patient is literally hurting their mother. A lot of our patients are adults. All of our patients are adults. And their parents, therefore, are even older than their children. So we have parents who are maybe in their 70s, and we're telling them like, oh yeah, physically block your child from getting to the refrigerator. It's probably not gonna go well. So a lot of times we won't even recommend extinction. It would be the best if we could do that. So the treatment effects are the best when you can do extinction, but it's not always possible. And so what do you do when it's not possible? One thing that we've been doing in our clinic and the research that we've been doing is something called manipulating the parameters of the reinforcer. So if you think about a reinforcer, and again, this is a little bit advanced, so if you have questions about this, I can talk more about it later. This is kind of just like a brief summary of what to do. So there are at least 3 parameters of a reinforcer. There's the quality of the reinforcer. It could be either high quality or low quality. There could be how long they have access to the reinforcer. They could have it for a minute or only 30 seconds. And there's also how immediate you provide the reinforcer. Are you providing it immediately, or are you delaying it? So typically, you would see the most responding for reinforcement when it's high quality, you get it for a long time, and you get it immediately. You see less behavior when you get the reinforcer, but it's a low quality, you get it for less time, and it's delivered after a delay. And so that's what we do to try to reallocate responding to the appropriate behavior, to the functional communication response, when you're still providing reinforcement for the problem behavior. So for example, let's say you have an individual who engages in problem behavior for attention. So Susan was the example that we had here. So Susan engages in problem behavior, let's say it's aggression, to gain access to attention. If we were to do functional communication without extinction, that means she's going to get attention for problem behavior and a communication response. If you're very familiar with behavior analysis, you know the matching law, which basically just says that behavior goes where reinforcement flows. That's what we say. It rhymes in English. So wherever you see reinforcement, you're going to see behavior. So you would predict that you would see both problem behavior and communication responses, which is not ideal, which is why the research used to say that you have to do extinction. But if you reinforce them differently, you see a switch. So if Susan engages in problem behavior, we're going to give low quality attention for a less amount of time and after a little bit of a delay. So Susan engages in aggression. I'm maybe going to count to like 5 in my head and be like, Susan, I really wish you wouldn't do that. And that's it. Short statement, low quality, delivered after a delay. But if Susan says, Julia, will you play with me? Oh my gosh, of course I can play. I love how you asked. Let's go play soccer. Let's have a dance party. Let's do whatever you want to do. So I'm going to give high quality attention immediately for a longer amount of time. And so if you manipulate those parameters, you do see a shift towards the appropriate response and less for the problem behavior. And so there are other modifications that you can do as well, especially you can do this for other functions as well, not just attention. You can do it for escape, intangible, and any idiosyncratic function that you identify. And there's a lot of modifications that you can do in addition to this when you're working with adults. So if you have more questions about that, feel free to ask during the Q&A. But for now, I'm going to keep on going because I am running a little bit short on time. Okay. So back to Bruce's functional communication treatment. So this looks great, right? Are we ready to have a party and celebrate our success? Let's look at a different graph. So this is in the same evaluation, but now we're looking at his compliance. So when we tell him to do something, is he doing it? So now we have graphed here 0 to 100% compliance. So if he were to do work every time we told him to, we would see at 100. We're not really at 100 right now. So Bruce is not engaging in problem behavior. Yay. But he's also not doing work. He's not doing anything. So how are we going to increase that compliance? And so good things about our treatment evaluation, we decreased aggression and disruption, we increased a functional communication response, but we did not increase compliance. He's still not doing work. So how do we get work to be on the green side? How do we increase that? So that's what component 5 is for in his treatment plan. This is the other DRA component. So this component is using the token board, which you see right here in front of Tori. So on the token board, it states that if Bruce does his work, he gets a check mark. I think the protocol that you guys have, it says a token board, a token. So you could have like laminated tokens, but it was easy to travel on an airplane here with dry erase markers on this board instead of tokens. So we have dry erase markers and check marks, which works just the same. So then once Bruce gets 10 of his check marks, he gets his iPad, which we identified yesterday in the reinforcer assessment does increase other behavior. So our problem is that Bruce is not working. What do we need to increase behavior? We need a reinforcer. And we identified one yesterday. We're going to use the iPad. So you wouldn't just start out right away with 10 tokens to get your iPad. A lot of times it would just be do one thing and I'll give you your iPad, just to make sure that the iPad is working. And then you would thin the schedule of reinforcement. You keep hearing this term. So you would do that here too. So first, maybe 2 check marks, you get your iPad. Then 3, then 4. You would have some sort of an end goal in mind as you're doing this. And so for Bruce, the end goal was 10 tokens. So Bruce gets 10 tokens or 10 check marks and he gets his iPad. So here's an example of what that looks like.
All right, Bruce. Write your name. Nice job. You earned a check mark. Fold the towel. Awesome job. You earned your last checkpoint. All right. You earned your iPad.
That's exactly how it would work. And if at any point in here Bruce said, I want a break, sure, you can have a break, but he's not going to get a check mark because he didn't do anything. So he can still ask for a break if he wants to, but if he decides to do his work, he gets his iPad. So that's how those two components work together. So I want to, I'll show you the graph, and then I do want to do a quick other role play because when you guys are doing the check marks, it's also a good time to practice the spear prompting that we talked about first. So let me show you his results, and then we'll do some more practice really quickly. So in our baseline, when he's not earning his iPad, we see his compliance is around 20%, which is not ideal, especially if we want Bruce to ever have a job. He has to be able to do work to get a job. So when we then implement the iPad, we see compliance come up to almost 100%. And again, to make sure that it's our treatment that's effective, we're going to go back to baseline. And we see that when he doesn't earn his iPad, when we take the token board away and the iPad, he stops working. So we know that it's our treatment that's working. We go back to treatment. iPad is working. We thin the schedule, so maybe this is where we get from 1 token to 10 tokens. We generalize, we make sure that it works. Same that we did with functional communication, we make sure it works in other environments, specifically the regular environment with regular caregivers, and then we can go ahead and put it into our treatment plan that you guys have. All right, so let's practice. So you guys can do the work with the token board. If you can engage in functional communication too, if you say, I want a break, then you get a break. And as you're doing the work, you can practice spear prompting too. So if you're the actor pretending to be Bruce, maybe be a little bit non-compliant so people can practice the spear prompting too. So hopefully this will be quick, and then I'll get back to the talk. Okay, everyone, we are 2 minutes over for our break. So if you guys have questions, the talk after this, the next part, is shorter than this one, so we'll definitely have time for Q&A there. So if you have any questions related to this talk, save them for the next Q&A, and I promise I'll save time then. Okay, so have a nice break, and I'll see you in a little bit, unless you have something to say. Okay, hold on one second.